Okay. Okay. Good afternoon. I'm Ann Wong with the Illinois Chapter, American Academy of Pediatrics, and I thank you for joining us for today's webinar on promoting the HPV vaccine. This webinar is sponsored by the Illinois Department of Public Health. Today we are joined by Dr. Anita Chandrapuri. All participant phone lines are muted. This webinar is being recorded. If you have any questions for our speaker during the presentation, please enter them into the question box on your control panel for the webinar on the right-hand side of your screen, and Dr. Chandrapuri will answer them at the end of the presentation. I would now like to introduce Dr. Anita Chandrapuri. Anita received her medical degree from Northwestern University School of Medicine and conducted her residency at Children's Memorial Hospital in Chicago. She currently practices pediatric medicine at the Northwestern Medical Group in Chicago and serves as an instructor in clinical pediatrics at Northwestern University School of Medicine. Dr. Chandrapuri is board certified in pediatrics and is a fellow of the AAP. Please join me in welcoming Dr. Chandrapuri.
Good afternoon, everybody. So as Ann mentioned, I work with Northwestern Medical Group here in Chicago, and I help to serve on the ICAP immunization faculty. So thank you for having me here to speak to you about the HPV vaccine. Really briefly, I just wanted to disclose that I have no relevant financial relationships with the manufacturers of the HPV vaccines, and I don't intend to discuss any unapproved or investigative use of the vaccine. The objectives of this presentation are to understand the challenges in HPV series completion and suggestions for improvement, to understand the better coverage potential with the new HPV vaccine, HPV 9 vaccine or Gardasil 9, and to understand in general more about adolescent vaccinations and barriers. So we're going to really briefly talk about adolescent vaccines and then bridge right over to the HPV vaccine and how and your role in improving vaccination rates and reducing missed opportunities for vaccination. Everybody knows about and remembers about childhood vaccinations. In terms of the preschool and pre-kindergarten vaccines, it's all sort of ingrained in not only our providers but also our patient population that there are several vaccines at that age. It's important to have our patient population and parent population actually really understand that adolescents need vaccines too. The current adolescent vaccine recommendations include the Tdap booster, the meningitis vaccine, which we know this year has a 2-dose requirement by the time you hit your senior year in high school. The HPV vaccine, which is a 3-dose vaccine. Currently, we have the Gardasil vaccine, and then the Gardasil 9 vaccine is licensed and will be available to most people soon. And then the influenza vaccine. In addition, there's another meningitis vaccine, a meningitis B vaccine, which is licensed for adolescent use as well, and it's currently being discussed at the ACIP in terms of its formal recommendations. If we look at our pertussis vaccine recommendations, the Tdap booster, you know that there's the Boostrix GSK product, which is recommended for 10 years of age and older, and then there's the Adacil Sanofi Pasteur product, which is for 11 to 64 years of age. The recommendations at 11 to 12 years of age catch up truly from any point onwards. Beyond that, the recommendations, as many of you know, really include all adults beyond the adolescent period to receive at least one pertussis-containing booster vaccine. At this point, it's only one pertussis booster vaccine. The remaining 10-year tetanus boosters are just the TD vaccine. And then, of course, in pregnant women or your pregnant adolescents, it would be one vaccine with each pregnancy. The meningococcal or MCV4 covering strains A, C, Y, and W135 is routinely recommended for adolescents, preferably at age 11 or 12, and then a booster dose 5 years later. The current school requirement is a vaccine entering 6th grade and then a second vaccine enter after the age of 16, so by the time you're a senior in high school. Let's talk about the HPV vaccine. The HPV infection. 4 out of 5 people will be infected with HPV at some point in their lives. That's an estimated 80 million Americans that are currently infected, 14 million new infections per year in the United States. And HPV infection is most common in people in their teens and early 20s. With HPV infection, most people will never know that they have been infected. Fortunately, most people are able to clear their own HPV infection. And HPV infection then becomes a problem for them if it remains dormant in their system without them being able to clear it, such that later on in life they develop either genital warts or different cancers associated with the HPV infection. HPV exposure can occur with any type of intimate sexual contact. Intercourse is not necessary to become infected, and this is something that providers certainly should understand, but it's important for our patients and their parents to understand exactly that it does not take intercourse, but any type of intimate sexual activity. We actually, one of my partners in my office actually describes this as the common cold of sexual activity because it is such a common transmission. And it's important for our patients and our patients' parents to understand that nearly 50% of high school students have already engaged in sexual intercourse, be it vaginal or penile or other forms of intercourse. And I think that that's something that a lot of parents fail to believe, fail to understand. Of 9th graders, a third report that they have been sexually active. Of 12th graders, 2/3 report that they have been sexually active, a quarter of whom have had 4 or more partners. So you can definitely see how HPV can be transmitted amongst this population of adolescents. This is a self-reported study of acquisition of HPV after sexual debut, and it basically showed that in this group of college students that were interviewed, 50% of males became HPV or got HPV within 2 years of sexual debut, and for females it was 40% within 2 years of sexual debut. So you can see again that this is a very commonly spread infection. If we look at the average number of new HPV-associated cancers by sex in the United States, this is over 5 years ago. Now we're seeing more and more oropharyngeal cancers in both men and women. But in women, over 20,000 patients have HPV-associated cancers, or the incidence of new HPV-associated cancers is around 20,000 in women, and in men around 12,000, the majority of which are cervical cancers in women, the majority of which are oropharyngeal cancers in men. But like I mentioned, the oropharyngeal numbers are increasing in both men and women. Cervical cancer, as of right now, is the most common HPV-associated cancer among women. Over 12,000 new cases, like the previous slide showed, 4,000 attributable deaths in the United States per year. And interestingly, nearly 2/3 of cervical cancers occur in women younger than 55 years of age. This is not a cancer necessarily of just the older population. Roughly 15% between 20 and 34 years of age, roughly 25% between 35 and 44 years of age, and another 25% between 45 and 55 years of age. So these are young patients. If we look at HPV-associated cervical cancer rates by race and ethnicity, in terms of race, there's a greater number of cervical cancer patients with cervical cancer in the Black population, and a greater number in the Hispanic population. This may be attributable to healthcare access, understanding of the transmission and the disease process, and different prevalence of sexual activity rates in both of these populations. So what can we do? What is our role in preventing HPV disease? There are currently 3 licensed vaccines: the bivalent vaccine, or Cervarix, which contains the strains HPV 16 and 18 and protects against HPV-related cervical precancers and cancer in women. The quadrivalent vaccine, or the Gardasil product, which contains the strains 6, 11, 16, and 18, which helps to protect against HPV-related cervical, vulvar, vaginal precancers and cancers in women, anal precancers and cancers in women and men, and genital warts in both women and men. Strains 6 and 11 are attributable to 90% of the cases of genital warts in both men and women. And then there's the new nanovalent vaccine, or Gardasil 9, which has 5 more strains added to it. This again protects against HPV-related cervical, vulvar, vaginal precancers and cancers in women, genital warts in men and women, and anal precancers and cancers in women and men. If we look very briefly at the relative contribution of HPV types in the 9-valent HPV or Gardasil 9 product, HPV-16 seems to be the supervirus. This accounts for about 60% of HPV-related cancers. If you add on HPV-18, that's 70% of all HPV-related cancers. The remaining 5 add on another 20% coverage against HPV-related cancers. So with this nanovalent product, we hopefully will be able to protect our patients who receive the vaccine against 90% of the strains of HPV that can lead to cancers in their lives. Again, HPV 16 and 18, you can see with the red bars here, are the most important in terms of cancers related to HPV. The other strains do provide additional protection, which is a nice thing about the new vaccine, because we can cover against more strains that can lead to cancers in these patients' lives. So if we just look at the timeline of what's been going on with the HPV vaccine. In 2006, the initial recommendation was made for HPV-4, the Gardasil product, to be given at 11 to 12 years of age or 13 to 26 years of age if not previously vaccinated in women. And then in 2009, HPV-2 was recommended in females, and HPV-4 was given the permissive recommendation in males. In 2012, our HPV-4 product was recommended in a gender-neutral fashion to both men and women. And then in 2014, the HPV-4, and where we stood for females was that HPV-2 or HPV-4 was recommended at 11 to 12 years of age, all the way through 26 if not previously vaccinated. And then in males, the same thing. HPV-4 was recommended at 11 to 12 years of age, 13 to 21 if not previously vaccinated, or 22 through 26 for patients who are at high risk for developing or for contracting HPV. The HPV-2 product was never recommended for males. And then the 9-valent Gardasil 9 HPV product was licensed by the FDA in December of 2014, recommended for 9 to 26-year-olds females and 9 to 15-year-old males. The ACIP discussed this vaccine in February of 2016, and so the licensing, like I mentioned in the first part of this slide, is as above for by the FDA, but the ACIP discussed this in February 2016 and said that they would recommend age and gender recommendations the same as the quadrivalent vaccine. They recommended finishing the series with whichever vaccine is available to you, and they at that point had not determined what recommendations to make for those who are already fully vaccinated with the bivalent or quadrivalent vaccines. As I understand it, the ACIP is discussing this, though, this current week down at their meetings, further discussing this, I guess. So what do we know 9 years after this vaccine has been, since the initial Gardasil vaccine was licensed, about the effectiveness and safety of the HPV vaccine? We know that HPV infections have decreased in the United States from 2007 to 2010. If we looked at 14 to 19-year-olds, the vaccine type HPV prevalence decreased from 11.5% to 5%, which is about a 50% decrease. Other age groups did not show a statistically significant difference over time. The research showed that vaccine effectiveness for prevention of infection was an estimated 82%. And if you look at this is genital warts data in the United States. And if you look at the bright pink line, it shows that there was a steady decline in genital warts in the 15 to 19 age group, which remember was the earlier age group that was recommended to receive the HPV vaccine. The other age groups didn't get the benefit of getting the HPV vaccine. And then if you look at this data amongst females in Australia, and there is similar data actually for males as well in Australia, but the vaccine was first introduced in 2006 there, and the line shows a steady decrease in genital warts in the population, and they calculated out to be about 73% decrease in genital warts in the female population in Australia, according to this slide. The HPV vaccine is safe. We know that over 60 million doses have been distributed in the United States since 2006, nearly 175 million doses distributed worldwide. The most common adverse events were mild, and the VAERS tracking system is following for any other serious adverse events, but it found no causality between the HPV vaccine and serious adverse events. And these findings were very similar to the safety of the meningitis and Tdap vaccines as well. So if we look at our report card, the United States is not doing very well. This is data from the 2010-2011 monitoring time frame. Countries like Australia and the UK and Canada and even the Netherlands, where either the vaccine is required or there is a socialized medicine system or there is a better school distribution system of vaccine, there's a much higher rate of coverage of the HPV vaccine. In the United States, we're only in the 30 percentile range. And if we look at more recent data here within breaking it down between the United States, Illinois, and the city of Chicago, for a single dose, the United States has 57% of females getting a single dose of the HPV vaccine, compared to males only 34% getting the first dose of the vaccine. If we look at the 3-dose series, in females we're down to about 37%, which was the data I quoted earlier. In males it's far lower, only about 14%. Within our city of Chicago, it's roughly the same. 60% of females have gotten a single dose. 50% of our males have gotten a single dose, which shows that we're doing something in terms of educating our patients' providers and our patients' parents. But there is a steady decline in the number of patients who have gotten 2 or 3 doses, both in males and females. And you can think, okay, well, maybe that's because our adolescent patients aren't coming in for their vaccines, but the numbers are dramatically different than our Tdap and Menactra coverage rates. Granted, the Tdap and Menactra is both a requirement, but the way we look at this is that this should be a universal recommendation for all of our patients. So let's try and understand the reasons for non-vaccination. This was a survey that was done parents of girls. 500 mothers of 14 to 17-year-old girls were surveyed in 2010 from a national sample of patients, 50% of whom reported non-vaccinations of their daughter. So these were parents who were asked to indicate why they did not vaccinate their daughters. And the parental reasons reported were that they were concerned about side effects, they were concerned about the safety of the vaccine, but there was no doctor recommendation for the vaccine, there was no recent doctor visit, they were concerned of disinhibition of sexuality in their daughters. They doubted the efficacy of the vaccine, or they were concerned about no coverage of the vaccine by their insurance companies. If you look at a similar number of parents of boys who were asked also why they did not vaccinate, they reported that there was no doctor recommendation for the vaccine for their boys. They didn't even know that this vaccine was for the male population, that they were concerned about side effects, they were concerned that the vaccine was dangerous for their boys, or that they were also concerned about disinhibition of sexual activity. Other reasons that were reported were that they thought their child was too young, they did not think their child was at risk, they thought the vaccine was too new, or they questioned whether or not the vaccine actually works. So if we address each of these issues, that the vaccines are too new, or that there are safety concerns, or that the child is too young, we'll just go step by step and address each of these reasons. Are the vaccines really too new? The HPV-4 vaccine has been licensed and recommended for girls and young women since 2006, and the meningitis vaccine was licensed just 1 year prior. Millions of doses of the vaccine have been distributed in the United States and worldwide, over 100 countries. So are the vaccines really too new? No. Now, if you question the Gardasil 9 vaccine being too new, the studies that were done to license this vaccine have been bridging studies which show the same and not less efficacy of the vaccine, of the new product compared to the prior product. So that's also, while it's a newer vaccine in terms of licensing, it took data from the prior vaccine and showed relevant bridging efficacy to license this vaccine. Is the vaccine unsafe? No. Concerns are always based upon individual stories, which of course are tragic stories, but do not implicate the HPV vaccine specifically. And it's important to understand, what does the research show when large numbers of people are carefully studied? And we have data that shows that these vaccines are safe. Like I mentioned before, the VAERS data showed no significant concerns about safety, and these studies have been based on over 600,000 doses. The specific studies have been based upon over 600,000 doses of vaccine, which showed no increased risk for strokes, seizures, allergic reactions, or other conditions that have been proposed to be related to the vaccine. When people say their child is too young or not at risk, it's important to point out that the point of a preventive vaccine is to vaccinate before exposure, similar to how I tell patients that they should be wearing a seatbelt as soon as they get in the car, not only wearing seatbelts when they're planning on getting into accidents. The vaccine-induced anti-HPV response seems to be stronger amongst younger versus older teens. Most people will eventually be infected with HPV, or data shows that most people will eventually be infected with HPV, so nearly everyone is at some risk. In some studies of unvaccinated adolescents, like I mentioned before, most were infected within 5 years of sexual debut. And the vaccine protection lasts at least 10 years, probably even longer. So in terms of addressing the issue if your child is too young or not at risk, I think that this shows that there's really no reason or benefit to delaying vaccination. In terms of the vaccine efficacy, both previously licensed vaccines were significantly effective at preventing infection with vaccine HPV types. HPV-2 is effective at prevention of cervical precancers. HPV-4 effective at prevention of cervical, vulvar, vaginal, and anal precancers. HPV-4 is also effective at prevention of genital warts, and numerous clinical trials have shown this. Studies in Australia and Denmark have shown that successful implementation of HPV vaccination programs leads to marked decreases in cases of genital warts. There's evidence of herd protection, meaning that protection of one population or of a specific population is actually done well in terms of protecting the larger population at risk. And there have been numerous studies which show decreases in cervical abnormalities as well. So we know that the vaccine is effective. And even with relatively low vaccination rates in the United States, we found that there is decrease in prevalence of HPV-related illness amongst our 14 to 19-year-old girls. There's no evidence of waning effectiveness over the 8 years or so that studies have shown here in the United States. And there's good evidence that the vaccines, if needed, and if we use them as boosters, can help with maximizing antibody levels in our patients. So yes, it is very effective. Does vaccination lead to sexual disinhibition? I don't think that this is really an issue that a lot of parents are asking me about, but you can also, if you do have parents that ask about this, there have been several studies, over 15 studies published since 2012, which show that there's no increase in rates of pregnancy or other sexually transmitted illnesses or visits to various gynae offices or Planned Parenthoods in terms of increased sexual activity. So the real problem, I think, is that the HPV vaccine was not recommended by providers. Generally, healthcare providers support HPV vaccination, but they also do report barriers that are difficult in their own situations, whether it's cost of stocking the vaccine, concerns about reimbursement, their own questions about safety, and lack of knowledge about the HPV vaccines. And this has been a particular problem with our male patients. We know that there are several providers who are more comfortable vaccinating older versus younger adolescents and tend to sort of just generally recommend the vaccine, but not really talk about it with full strength or full force until later on in adolescent visits. There have been studies that show that when adolescents and parents receive a strong recommendation from their healthcare provider, the odds of being vaccinated were much, much higher. And we know that the earlier we vaccinate, the better the chance of getting coverage of all 3 vaccines, the better the protection for our patients, the better herd immunity, and so on and so forth. So what can you do? You can give a very strong recommendation about this vaccine. The recommendation is really to vaccinate it as a cancer prevention vaccine and to do it in a gender-neutral fashion. You want to start the conversation early and focus on this cancer prevention. You want to talk about how vaccines given well before sexual experimentation begins are important. You want to utilize the rapport that you have with your patients at an earlier age. You want to utilize the fact that they have good insurance coverage with their parents still at this age. You want to talk about the better antibody response in preteens as opposed to later on in adolescence. If you have the unfortunate opportunity to talk about an HPV-related cancer in somebody close to you, whether it's a family member or something, then that can be a way to persuade a family member. It's important to, of course, have time to talk to parents about their concerns as well, and to talk about the safety of the vaccine and the efficacy of the vaccine. We know that adolescents rarely come into the doctor, so it's important to screen immunizations at every visit. I think it's important, this is sort of the less is more strategy that the CDC has endorsed, which is to talk about the vaccine in the same vein that you talk about the Tdap and the meningitis vaccine. When a patient comes in for their 11-year-old visit, to talk to them about how they're here, they need to get their vaccines today, which include the Tdap, the Menactra, and the HPV vaccine. If it's discussed in the same forum, the impression upon the parents and the patients is that our physician or our healthcare provider believes that this vaccine is as important as the other vaccines that we are to get at this visit. You can think about having reminder or recall systems through your electronic medical records. You can have future ordering or standing orders that help to get the patients back in for doses 2 and 3. It's interesting that a lot of providers think that they're doing a really good job at vaccinating their patients against HPV, but when they actually get the chance to look at the hardcore data in their own practices, it's very interesting to many of them. And I've gone to various offices through some work with the CDC and the Illinois Department of Public Health and the Chicago Department of Public Health. And it's interesting how many providers find that their rates are actually a lot lower than they anticipated. So remember, if you remember anything or nothing else about this presentation, remember in terms of just educating your patients. You want to teach your patients about the benefits of vaccination. You want to advocate for timely and protective vaccinations for your patients. And you want to be an example as best you can in terms of immunizing yourself, your family, your coworkers, and your loved ones. It's really so many patients and parents will ask, well, what did you do, doc? What did you do for your own children? What did you do for yourself? And I think that that's one of the best ways to tell parents that you truly believe in what you're doing. And this goes for not only the HPV vaccine, but several other vaccines that we utilize in our populations. So I think that's kind of the gist of my webinar here. I think what we do next is open it up for you to ask questions, and Anne's going to jump back in.
Yeah, so if you guys have any questions at all, remember that you're supposed to enter them into the right-hand panel of the control bar. So right now we are going to go over some, and it looks like we have one question.
So the Adacel product itself, as far as I understand, is licensed at 11. The recommendation from the CDC ACIP is to vaccinate at 10 years of age, or to vaccinate as young as 10 years of age with the Tdap, but the Adacel product specifically was FDA licensed at 11, unless that has changed very recently. There are people who do use the Adacel product at 10 because that's what they supply in their offices. In our office, if we are going to give it to somebody who's under 11, we just make sure we tell our patients that this is off-label usage because it was licensed at 11. And if you have knowledge differently, please feel free to share that with the group.
Okay, so let's wait a few minutes right now and see if anybody does have any questions. It's located once again on the right-hand bar of the control panel. So okay.
Denmark released information. Okay, we're going to go to this question. Denmark released information regarding Gardasil causing POTS as a side effect. Have you heard of this? I have not heard of this. Again, if somebody else can comment on that. Somebody asked, in the given too early section, you talked about it lasting 10 years. That only takes them to 21. And that, I believe, is referencing HPV. At this point, because the vaccine was licensed in 2006 in the United States, we only have data this long. But as time goes by, hopefully we'll have more and more data that shows that the vaccine protective nature is lasting even longer than 10 years. So it's hard to comment on whether or not there will need to be a booster. The next question is, what do you recommend when discussing this with providers with the differences in the ages for the Gardasil versus Gardasil 9? At our last med management meeting, our doctors didn't see the reasoning to switch to the Gardasil 9 because even with the added coverage, it didn't cover like the original Gardasil. I'm not sure what that means, that it didn't cover like the original Gardasil. If you're referring to the fact that for males it's recommended until age 15, and then the Gardasil 4 product is recommended for later, that's actually being discussed at the ACIP, such that there will only be one recommendation for Gardasil 9, gender neutral for all patients. As far as I understand it as well, that once over time, there's a possibility then that the Gardasil 4 product will no longer be manufactured and it will just be Gardasil 9 that will be available. Is syncope the most common side effect still? Yes, it is. It's recommended that you have adolescent. Do we have to have them wait 15 minutes after the vaccination? The recommendation is that for all adolescent patients, for all adolescent vaccines, to have patients wait for 15 minutes after vaccination. It is that the syncope side effect is something that is a known side effect for all adolescent vaccines and not just for HPV. This question, I think, has gotten cut off, but along with the increased cost, our doctors just can't see why they need to go with the Gardasil 9. There is an increased cost in production of the Gardasil 9 product, but the insurance companies are aware of that, and there are, it's hard to say which provider or which insurance companies you specifically have in your practice, but there are several insurance companies that actually will cover Gardasil 9 along with vaccines for children. I got a message here that also just reminds me that ACIP recommends Gardasil 9 for both men and women 9 to 26, but the FDA indication is for 9 to 15. The ACIP supersedes the indication, and all insurance covers Gardasil 9 for boys. Okay, I'm sorry, the questions are kind of coming in cut off. So how do you feel about the approach of starting Gardasil at 10-year well visit, considering we should see them back at 11, so that pretty much guarantees us 2 doses in with 1 more to get in? So the licensing of the Gardasil product is at age 9. The ACIP recommendation is at age 11. So you're not doing anything off label by starting at age 10. It really depends upon your patient population and how you can counsel your patients. There certainly is no problem with giving it at age 10, though. If started with Gardasil 4 series, is it okay to complete with Gardasil 9? Yes, that is the current recommendation from the ACIP, that you complete the series with whichever product you have. Will the new HPV vaccine be as painful as the Gardasil vaccine seems to be, especially when given to fasting children? I don't know that there will be any difference in the pain perception of the 2 vaccines. How much is Gardasil 9 as compared to the other one? I don't have specific data on the differences, but I do believe that there will be a cost increase in the Gardasil 9. What about the timeline? If they miss, they do not start over. That still remains the same. You do not need to make up or repeat a dose if the spacing or the intervals are greater than the recommendation. The current recommendation is 0 times 0 times 2 months and then times 6 months. D. Prettyman got back to me and said, FYI, the package insert for Adacel indicates for persons 10 through 64, which is fantastic if they got it re-licensed. That is re-FDA approved. So if that is the case, then Adacel is down to 10, and I appreciate you letting me know that, D. Is Guillain-Barré still a side effect? It is a contraindication to giving the HPV vaccine if somebody's had Guillain-Barré. Recently, it is not thought it is not a contraindication, though, in terms of the risk. So there's no increased risk of the HPV vaccine leading to Guillain-Barré. Similarly, there's no increased risk of the meningitis vaccine leading to Guillain-Barré. So it's not the only contraindications if you've had Guillain-Barré. Is Gardasil 9 as compared to the other ones given at the same interval? It's actually given at time 0, time 2 months later, and then 6 months later. I'm just reading these questions as they're coming in. I hope that this is all okay and that people are understanding the answers and responses. I think I got everything. I apologize about the Adacel confusion. That is something that I will update in the slide deck as well.
Okay, so that looks like we've covered all of the questions that people have. I just wanted to thank everyone for participating in today's webinar, and I hope that you all have found this webinar informative and that it answered many of your questions regarding the HPV vaccine. Later this afternoon, you will receive an email from me with a link to today's recorded webinar, as well as a PDF copy of the slide sets. And later, you will also be receiving an email from Rush University regarding a survey that you would need to fill out about the webinar. Please complete the evaluation in order to receive your CME and or CNE credits. So
can I give you one more update? It looks like the Gardasil 9 product is about 11% more than cost-wise than the Gardasil 4 product. It depends upon your provider's contracts in terms of purchase costs, but that is roughly about $12 more per vaccine.
Okay, thank you. So that about wraps up our webinar on promoting the HPV vaccine. Thank you once again to everyone for joining us on today's webinar. And the email won't be coming out immediately after this webinar, but everyone will receive an email from me before the end of business day. Thank you.